good afternoon, everyone. Let's carry on with interventional radiology. I would like to present my PhD thesis topic, Impact of Navigational Systems on CT-guided interventions. My name is Mátyás Rédei. I work at the Medical Imaging Center, and throughout my PhD research work, we would like to improve CT-guided interventions with navigational systems by investigating these implications of different procedures. Therefore, we aim three specific goals throughout my PhD work. First of all, we would like to investigate different type of CT-guided interventions and different kind of navigational systems in the framework of a systematic review and the meta-analysis. And in the second project, we are investigating multiple peri- and post-procedural maneuvers during these interventions. And lastly, we are also investigating our self-developed navigational systems, but the lack of time, I would like to introduce the first two projects of mine. So let's jump to the first one, investigating the safety and effectiveness of navigational systems for patients undergoing CT-guided interventions. There are various types of CT-guided interventions, such as biopsy, tumor ablation, drainages, sympathetic disease, and so on. And to compare them, it's important to excel that the first procedural step which they share is the needle insertion. The needle insertion without navigational systems is really time-consuming, and therefore it increases the radiation, and therefore multiple needle manipulation is needed during the procedure, causing more complications and even long waiting lists for the patient. But by implementing navigational systems, the irradiation dose can be decreased by 50%. The procedure duration can also increase by almost 40%, and the complication is also reduced by almost around 7%. So we would like to assess the safety and effectiveness of the systems for these patients. So our investigated population is patients undergoing CT-guided interventions, and we compare the utilization and non-utilization of these systems to assess outcomes such as number of needle manipulation, procedure time, and irradiation dose, besides complication rates and success rates as well. And we think and we hypothesize that using navigational systems improves efficacy and safety in CT-guided interventions. This was the systematic search we conducted according to the search key which is visible on the slide, and we managed to include 36 articles into the analysis. So let's jump to the first one. The most important outcome is number of needle manipulation, since the other outcome is really related to this one. We managed to include 14 cohort studies and 6 randomized control trials, and the subgrouping is visible on the forest plot. During the analysis, we observed high heterogeneity, which is due to that there are various types of navigational systems, various targeted organs, and even the population was different. And we have to excel the expertise of the operator is really important during this outcome. But finally, we managed to observe that the mean difference between the two compared group is about 3, which means that 3 manipulation less is needed to reach the target, what we want to reach. The second outcome parameter is procedure time. And now we also address the high heterogeneity by subgrouping for thermal ablation and biopsy. And I would like to draw the attention to the thermal ablation group, where we observe that the procedure time is less by 12 minutes. And in the other group, in biopsy group, the procedure time is less by around 5 minutes, which is clinically highly relevant, since this intervention takes about 20 to 25 minutes per patient. The third outcome parameter is irradiation dose, which was a bit difficult to assess, since there is a variety of units how we can measure the irradiation. Therefore, we accepted that we are going to use ratio of means, and with about 2,000 patients, we managed to observe a reduction by almost 40%, which correlate with the literature data. Regarding complication rates, there are multiple complications such as hemorrhages or bleedings, other types of bleedings, but the most important are PTX, pneumothorax rates. On the first forest plot, we can see no real difference between the two compared group regarding PTX rates, but on the second forest plot, it's important to highlight that in thermal ablation group, the PTX with chest tube insertion, we think that clinically relevant PTX rates is when the patient needs chest tube insertion. In the thermal ablation group, is significantly lower with the utilization of navigational systems. And lastly, I would like to show the success rate. There are two types of them, technical and diagnostic success rate. Technical success rate is assessed during the procedure when the needle is precisely placed in the lesion that we targeted on the CT scan. And diagnostic success rate is a positive histopathological result regarding biopsies. So if we send the results to the pathologist and they find some pathological samples in the result, that diagnostically success. And we can see that there is the results favoring the navigational system group, both in technical, both in diagnostic success rates. So our strength is that this could be practice. This study has practice-changing potential and clinically highly relevant, and we can make recommendations for different procedures. But our limitation is that the applicability, since we cannot make subgroup analysis based on the different type of the navigational system, is restricting us. And also we observe high heterogeneity. We try to fight this high heterogeneity with subgroup analysis, but still observe some moderate heterogeneity in the subgroups. So navigational systems in CT-guided interventions boost efficacy, accuracy, and reduce complications, and we should implement in everyday practice. And further, we would like to investigate different types of navigational systems and identify the best for different procedures. So now our manuscript is under review in the European Journal of Radiology. The second project is comparing complication rates per protocol versus standard method in CT-guided pulmonary biopsies. This is a protocol of a randomized control trial. Percutaneous CT-guided biopsy has great advantages of a technical success rate nearly 100%, with a diagnostic accuracy around 90%, and it can be conducted under local anesthesia. But as we mentioned, a high pneumothorax rate is really a disadvantage, with a 5 to 10% of chest tube insertion. So to lower this complication, we can use navigational systems, as we provided information in the last study, and we can implement per protocol, which is an acronym for patient positioning biopsy side down, needle removing during expiration, autologous blood patch sealing, rapid rollover after the procedure, and pleural patching also with autologous blood patching. There is a cohort study conducted in 2021, and they had the results of lower pneumothorax rates and with chest tube insertion with the same diagnostic accuracy. And therefore, we would like to investigate patients undergoing CT-guided lung biopsy. And with or without implementing per protocol, we would like to assess pneumothorax rates and chest tube insertions, besides complication rates and success rate. And furthermore, we would like to implement the per protocol in our everyday clinical practice. Our additional activities during PhD studies that we managed to present this data in different national and international conferences. And I also had the opportunity to join a first-year student, Shahar, with his first project. And I would like to thank your attention with the quote of Anna Esho, "Innovation is the calling card of the future." Thank you very much.
It's a really interesting topic, and I would like to ask which if you use navigational systems in your institution, or which type of navigation system do you use, if the answer is yes?
Yeah, so there are various types of them. At our clinic, we use electromagnetic navigation systems and also stereotechnic navigational systems, but there are plenty of other ones like laser navigational systems. The newest ones are virtual reality navigational systems.
Based on your knowledge, which will be the best for the patient? Which navigation system?
Well, I think there is a good answer. It depends. It depends on what we would like to do. For example, during a lung biopsy, we expect the navigational system to be really easily implementable, really small, and very adjustable to the patients and to the desk. And for example, in ablation therapy for also lung or liver, precision is much more important for the patients, since during a lung biopsy, if we can do multiple CT scan, whether the needle is located well, we can just readjust the needle, then manipulate the needle for the target. But in ablation therapy, it's really difficult to assess the volume of the tumor and how many needles do we need. So that's why precision is much more important.
I have one question, because in our field we use the navigational systems as well, and we can see a big price difference. Do you know anything in your field between the prices or the money gaps?
Yeah, there is. Well, actually, there are different types of navigational systems, but usually the advantages of being cheaper wins. So different brands make one type of navigation systems, and they can just vanish the other ones from the market. And usually there are just one flagship. And yeah, regarding precision, I think the most expensive factor of navigation system is the precision.
Can you go back to the first forest plot? I saw some interesting thing there. Yeah, there is this 0 in Dong study in the mean. Can you explain the 0?
Yeah, sure. This outcome is number of needle manipulation. It does not count the insertion. Insertion is 0, and that means in that study they do not have to manipulate the needle during the procedure. The first step was accurate.
Okay. It's nice. And my question is related also to this, that we see a difference between the cohort and the RCTs. That is normal that we can have. Do you have any idea what are in the background? So in the cohort, maybe the choice between the two is influenced by other factors, or?
I think there is a confounding factor and a publication bias as well, since these articles are usually written in Chinese and Japanese, and therefore there were some studies we could not reach for data, and also I think there are also articles which are not published in English. So therefore, and I guess they are not statistically significant or favoring the navigational system, and therefore is there such a deviation. And all the RCTs are English RCTs. We do not have to require special data. But if we inspect the prediction interval, future studies may favor navigational systems. There is a bit overlap, but based on our clinical experience, it's highly unlikely that new studies would go on the other side of the null effect line.
So I was glad that you mentioned confounding. So it was a good point. So thank you for your answer. So it is not possible that more complex confounding are in the background. So this means that cohort studies are we just take notes from things. It is not possible that the result is also influenced by the choice of the physician.
Yeah, there's
Which
selection bias as well, and even the blinding is questionable, since you cannot blind a physician if he's using the navigational system or not using the navigational system. So therefore, future RCTs are expected, since you cannot avoid blinding or cannot just avoid selection bias.
Okay, so thank you very much, the informed answers.
Thank you.